This is the second lecture for GI physiology. We will look at mixing and propulsion of food in the gastrointestinal tract. These two processes are controlled by nervous and hormonal mechanisms. Today, we will cover 4 topics. First, we will look at chewing and swallowing. Chewing, also called mastication, is a process to break apart cells, increase surface area of food, and mix it with saliva. Especially mixing food with saliva starts digestion of starch with alpha amylase and lubricate foods for swallowing. Most of the muscles of chewing are innervated by fifth cranial nerves, and the chewing process is controlled by a nuclei in the brainstem. Much of the chewing process is controlled by a chewing reflex. Presence of food in the mouth initiates a reflex inhibition of the muscle of mastication. As a result, muscles of mastication relax. This allows the lower jaw to drop, which in turn initiates a stretch reflex of the jaw muscle that leads to rebound contraction. This raises the jaw to close the teeth and compress the food against the lining of the mouth, which inhibits the jaw muscle once again. So this is a repeat again and again until the food is fully broken down. Swallowing can be divided into 3 stages. In the voluntary stage, food is voluntarily squeezed and pushed into pharynx by the tongue. In the pharyngeal stage, food passes through pharynx going into esophagus. In the esophageal stage, food passes through esophagus going into the stomach. We will take a closer look at the pharyngeal and esophageal stages. At the pharyngeal stage, as the bolus of food enters the posterior mouth and pharynx, it stimulates epithelial swallowing receptor area all around the opening of the pharynx. Impulse from these pass to the brainstem to initiate a series of automatic pharyngeal muscle contractions. More specifically, the soft palate is pulled upwards to close the posterior nares to prevent the reflux of food into the nasal cavity. The palatopharyngeal folds, which are not shown in this picture, are pulled medially to approximate each other to form a slit. Only bolus small enough can pass the slit with ease. The vocal cords are approximated and the larynx is pulled upwards anteriorly. Epiglottis now cover the opening of larynx. Trachea is closed. The upper movement of larynx also pulls up and enlarges the opening of esophagus. Upper esophageal sphincter relaxes. The entire muscular wall of pharynx contracts, beginning in the upper part, then spreading downward, which propels the food by peristalsis into the esophagus. This whole process can be represented in a short video. This is video 1. Swallowing is controlled by swallowing reflex. that involve the swallowing center in medulla and the lower pons. Sensory inputs from pharynx and esophagus are transmitted to the swallowing center through cranial nerves 5 and 9. In pharyngeal stage, the most sensitive tactile areas lies in the ring around the pharyngeal opening. Motor impulse from the swallowing center are transmitted to pharynx and esophagus through cranial nerves 5, 9, 10, and 12. Swallowing center briefly inhibits respiratory center during swallowing. Upper one-third of esophagus uses striated muscle. It is controlled by skeletal nerves impulse from cranial nerves 9 and 10. Lower two-thirds of esophagus uses smooth muscle. It is controlled by vagus nerves connected with esophageal mesenteric nervous system. In esophageal stage of swallowing, primary peristalsis is a continuation of pharyngeal peristalsis. Secondary peristalsis is induced by distension of gut wall. It repeats until bolus is cleared. This slide shows you esophageal pressures during swallowing. This is upper esophageal sphincter, and this is lower esophageal sphincter. The x-axis represents time in seconds. Y-axis represents pressure in millimeter mercury. At the rest, all the pressures are low, except pressures at upper esophageal sphincter and lower esophageal sphincter. When food enters the pharynx, there's a spike in pressure in pharynx. At this moment, due to receptive relaxation, the upper esophageal sphincter relaxes. The pressure spikes lower. The food enters the esophagus. When food is in the esophagus, the pressure stays high. But far before the food arrives in the lower part of esophagus, lower esophageal sphincter relaxes. The pressure goes lower. After the food enters the stomach, the pressure goes back up. This information is summarized in this slide. Please note, relaxation of sphincter and fundus is mediated by VIP, produced by vagus nerves. As I described to you earlier, primary peristalsis is a continuation of pharyngeal peristalsis. It is controlled by the swallowing reflex that involves the swallowing center. It cannot occur after vagotomy. Secondary peristalsis is controlled partly by intrinsic nervous circuits and partly by swallowing center. It can occur after vagotomy. Here is a clinical correlation. We will look at disorders of swallowing. First condition is paralysis of swallowing mechanism. In patients with this condition, normal swallowing does not occur. Food may pass into the lung or reflexes into the nose. This condition may be caused by damage to the cranial nerves or damage to swallowing centers by viruses such as polio, or paralysis of swallowing muscles. as occurs in muscular dystrophy, myasthenia gravis, or botulism. One of the most serious instances of paralysis of swallowing mechanism occurs when patients are in deep anesthesia. Second condition is achalasia. It arises when muscles of lower part of esophagus fail to relax, preventing food from passing into the stomach. After months or years, megaesophagus develops, in which esophagus can hold over 1 liter of food. This often leads to esophageal ulceration, rupture, and death. This condition is caused by damage in the neural network of mesenteric plexus in the lower two-thirds of esophagus. At the end, lower esophageal sphincter fails to relax. For management, antispasmodic drugs that relax smooth muscle can be helpful. Considerable benefits can also be achieved by stretching the lower end of esophagus by means of pneumatic dilator, an inflated balloon. The third condition is gastroesophageal reflux disease, or GERD. It is characterized by acid reflux into esophagus. This condition arises due to poor closure of lower esophageal sphincter. Factors that contribute to GERD include hiatal hernia and obesity. Typical symptoms of GERD also include heartburn, bad breath, chest pain. GERD can lead to stricture of esophagus, reflux esophagitis. It is the inflammation of esophageal epithelia, and Barrett esophagus, in which squamous epithelial cells of lower esophagus change to columnar epithelial with goblet cells. These cells are typically found in the intestine. Now, let's move to part 2. We will look at gastric motility. Anatomically, stomach is divided into two parts, body and antrum. Physiologically, stomach is divided into orad, which comprise about two-thirds of body, and caudad, which comprise the rest of body plus antrum. Smooth muscle from orad area can relax to accommodate food. Smooth muscle from caudad area functions to mix food with gastric juice and prepare food into duodenum. These two functions are also called retropulsion and entropump, respectively. When the stomach is empty, low amplitude contractions occur in the orad smooth muscle. When food is coming, vagal reflex triggers receptive relaxation of the orad area. Stimuli are transmitted through vagal afferent sensory nerves to the brainstem and back to stomach through vagal afferent nerves. Vagotomy abolishes this reflex. Pressure in the stomach remains low until a limit is approached. Food causes distension of the gastric wall. The capacity of being distended is called gastric distensibility. CCK increases the gastric distensibility. When the food volume hits a limit, peristaltic constrictor waves or mixing waves begin in the mid to upper portion of stomach and moves towards the antrum. They become more and more intense that forces the antral contents toward the pylorus. This process is better represented in a video. This is video 2. As I described to you in the previous lecture, slow wave depolarization typically does not trigger action potentials in the smooth muscle of the GI tract, but in stomach it does so. Slow waves elicit muscle contraction with contraction frequency about 3 per minute. Larger slow waves that have spike potentials cause increased strength of smooth muscle contraction in stomach. The caudad area of the stomach functions as a pump to propel food into the duodenum. The antral pump is driving force for gastric emptying. It is accomplished by stomach, pylorus, and small intestine. This is the stomach immediately after a meal. Under conditions that favor emptying, peristaltic constrictor waves or mixing waves begin in the mid to upper portion of the stomach and move towards antrum. These waves squeeze the food. The volume of stomach decreases. When intestinal receptors are activated, they send a signal to stomach to relax orad and inhibit antral pump. Gastric emptying occurs at a proper rate so that pH will be optimal for enzyme function. It is slow enough for nutrient absorption. Conditions that favor emptying include increase the tone of orad stomach by increased food volume, increased antral contraction triggered by volume and gastrin level, relaxation of pyloric sphincter, and absence of segmentation contraction in the small intestine. Factors that inhibit gastric emptying are derived from nervous reflexes and hormones. 3 nervous reflexes from duodenum provide inhibitory effect. First, stimuli such as acid irritants in the duodenum activate receptors in the epithelium. Signals are transmitted by an intrinsic pathway through afferent fibers within the enteric nervous system and back to stomach. Second, signals are transmitted by an extrinsic pathway through prevertebral sympathetic ganglia and back to stomach. This is the enterogastric reflex that I described to you in a previous lecture. Third, signals are transmitted by an extrinsic pathway through vagus nerve to brainstem and back to stomach. Hormones from duodenum also provide inhibitory effects. In particular, 3 hormones that act as enterogastrone, CCK, secretin, and GIP. GIP is glucose-dependent insulinotropic peptide. Here is clinical correlation. There are 2 common disorders of gastric motility. One is slow gastric emptying, and the other one is rapid gastric emptying. Slow gastric emptying is the most common problem in this group. Patients with this condition have sense of fullness, loss of appetite, nausea, and sometimes vomiting. It could be caused by gastric ulcer, vagotomy, eating disorder, and cancer. For treatment, balloon dilation can be helpful. The opposite condition is rapid gastric emptying. Patients with this condition often have diarrhea, hypotension, reactive hypoglycemia, and duodenal ulcer. It typically occurs after surgery to remove all or part of stomach or stomach bypass surgery. For treatment, changes in eating habits with a smaller meal each time often can improve the condition. If not, medications such as anti-diarrhea drugs can be used. Now, let's move to part 3. We will look at small intestinal motility. Small intestinal motility contributes to digestion and absorption by 3 means. First, mixing chyme. It helps mix chyme with digestive enzymes and other secretions. Second, circulation of chyme. It helps achieve optimal exposure of chyme to mucosa. Third, propulsion of chyme. It helps move chyme towards the anus. There are 2 types of movements. One is peristalsis and the other one is segmentation. Peristalsis in small intestine is very similar to the one in pharynx, esophagus, and stomach. It involves longitudinal smooth muscle. Segmentation is a mixing movement that I have described to you in the previous lecture. It involves circular smooth muscle. Segmentation contraction is controlled by slow wave activity. Slow wave frequency is 12 per minute in duodenum, 10 in jejunum, 8 in ileum. Contraction frequency is limited by slow wave frequency. For example, maximum frequency of segmentation contraction in duodenum is 12 per minute. In the small intestine, spike potentials are required for muscle contraction. This is different from stomach, where slow waves alone can cause muscle contraction. Segmentation contraction, although lasting for only a few seconds at a time, often travels 1 centimeter in the anal direction. This is a propulsive effect. As we have seen in the previous lecture, peristalsis is a distinctive pattern of smooth muscle contraction that propel food distally through the pharynx, esophagus, and intestines. It occurs in the form of peristaltic waves. Contractile ring moves towards the distant segment, pushing the content in the anal direction. The gut relaxes several centimeters downstream. The net movement along the small intestine averages only 1 centimeter per minute. As a result, it takes 3 to 5 hours for the chyme to move from pylorus to the ileocecal valves. Peristalsis in the small intestine is controlled by neural and hormonal signals. Neural signals include 3 major reflexes. First is peristaltic reflex, mediated entirely by enteric nervous system. It is an intrinsic reflex. Second is intestinal reflex. It is an inhibitory reflex, inhibition of activity elsewhere, where one part of it has become overdistended or as mucosa is irritated. It is also an intrinsic reflex. Third is gastroileal reflex. Stimuli from stomach are transmitted through prevertebral ganglia and back to ileum to relax ileocecal sphincter and increase ileal peristalsis. Among hormones and paracrines, motility, gastrin, CCK, and insulin, plus serotonin and prostaglandins are stimulants. Secretin, glucagon, and epinephrine are inhibitors of peristalsis. Peristalsis also occurs in other conditions. For example, during fasting, periods of intense peristaltic contractions occur. They appear in waves of electrical activity that sweep through the intestine in a regular cycle. They are called migrating motility complexes, or MMC. They are the most coordinated rapid peristalsis. It takes 90 minutes to travel from stomach to colon. They are mediated by motility and enteric nervous system. The purpose of peristalsis in this condition is to sweep undigested residue towards colon to maintain low bacterial counts in upper intestine. Another peristalsis occurs in infectious diarrhea. It is also called peristaltic rush. It is powerful and rapid peristalsis. Contractions travel long distance in the small intestine within minutes. It is mediated partly by extrinsic autonomous nervous system and brainstem and partly by enteric nervous system. The function of peristaltic rush is to sweep irritative chyme rapidly into the colon. Here is ileocecal valve, and this is the ileocecal sphincter. It is thickened, circular, smooth muscle. It regulates movements of ileal contents into large intestine. It is controlled by gastroileal reflex and extrinsic reflex. Ileocecal valve prevents backflow of cecal contents into small intestine. The valve can resist reverse pressure of over 50 to 60 centimeter water. Resistance to emptying at the ileocecal valve prolong the stay of chyme in the ileum and facilitate absorption. Finally, let's move to part 4. We will look at large intestinal motility. Functions of the colon are to absorb water and electrolytes from the chyme to form solid feces. Colon also stores fecal matters until it can be expelled. To fulfill these functions, smooth muscle of large intestine control mixing movements and propulsive movements, which in the large intestine are called Haustral contractions and mass movements, respectively. Similar to small intestine, movements in the large intestine are controlled by longitudinal smooth muscle and circular smooth muscle. In addition, surrounding the anus, there's an internal anal sphincter and external anal sphincter. Internal anal sphincter is made up of circular smooth muscle. External anal sphincter is made up of striated muscle. My enteric plexus, concentrated beneath tinea coli, controls longitudinal smooth muscle. Parasympathetic vagus nerves innervate proximal colon. Pelvic nerves control distal colon and rectum. Sympathetic nerves from celiac ganglion and superior mesenteric ganglion control proximal colon. Those from inferior mesenteric ganglion control distal colon. Those from hypogastric plexus innervate rectum and anal canal. Pudendal nerves control external anal sphincter. Each haustral is a small pouch caused by circulation, which gives the colon a segmented appearance. To form pouches, smooth muscle at the length of 2.5 cm contracts at each constriction. At the same time, longitudinal smooth muscle contracts as well. These pouches are dynamic. They appear and disappear every 30 to 60 seconds. Mixing movements by haustration facilitate fluid and electrolyte absorption. The colon has a particular type of propulsive movements. They are called mass movements. They are modified peristalsis. The purpose of mass movements is to move feces to rectum and stimulate defecation reflex. Mass movements cover the distance from transverse colon to sigmoid colon. It occurs 1 to 3 times a day in many people for about 15 minutes during the first hour after breakfast. It consists of contraction for 30 seconds followed by relaxation for 2 to 3 minutes. Then another round of contraction and relaxation. Mass movements are initiated by 2 reflexes, gastrocolic reflex and duodenocolic reflex. Defecation is controlled by 2 reflexes. One is weak intrinsic reflex. The other one is more powerful spinal cord reflex. The intrinsic reflex is mediated entirely by enteric nervous system and initiated when feces enter the rectum. Rectal distension initiates efferent signals that spread through my enteric plexus to descending colon, sigmoid colon, and rectum. Contraction of smooth muscle forces feces towards the anus. An internal anal sphincter relaxes. If the external anal sphincter is voluntarily relaxed, defecation occurs. The spinal cord reflex is initiated by rectal distension. Efferent signals are transmitted to sacral cord and then back to descending and sigmoid colon and rectum by way of parasympathetic fibers in pelvic nerves. Signals from the spinal cord reflex greatly intensify the peristaltic waves in the colon and relax the internal anal sphincter. The lower neurons in the segments S2 to S4 provide sensory and motor fibers for defecation reflex. They are intact when spinal cord is injured at higher levels. Efferent signals entering spinal cord initiate other effects as well. For example, deep breath, closure of glottis, and increased abdominal pressure. All these work together to move fecal contents downward. Here is a clinical correlation. We will look at colon motility disorders. The first condition is Hirschsprung's disease or megacolon. Babies affected with Hirschsprung's disease fail to pass the first stool within 48 hours of delivery. It is caused by absence of ganglion cells in the myenteric plexus in a segment of sigmoid colon. This segment becomes constricted. This leads to buildup of feces in normal proximal section of colon. This is a colon equivalent of achalasia. Management typically requires surgical resection of the colon segment lacking ganglia. Second condition is paralysis of defecation reflexes in spinal cord injuries. When an injury occurs between the brain and lumbar vertebra L1, intrinsic reflex and local cord reflex are functional. But voluntary control of external anal sphincter is affected and it remains contracted. This leads to constipation and retention of stool. This is known as upper motor neuron bowel syndrome. For treatment, a suppository or digital stimulation can be helpful. When an injury occurs at L2 or lower, only intrinsic reflex is functional. The result is slower and weaker mass movement. External anal sphincter also remains tight. This leads to constipation and incontinence. This is known as lower motor neuron bowel syndrome. For treatment, in addition to suppository and digital stimulation, stool softener and manual removal can be beneficial.